Hello, ladies and gentlemen, and welcome to the City Club of Cleveland. I'm Dan Moulthrop, Chief Executive here at the City Club. Thank you all so much for joining us today for a conversation with Toby Cosgrove, President and CEO of Cleveland Clinic and author of The Cleveland Clinic Way, Lessons in Excellence from one of the world's leading healthcare organizations. In a lot of ways, anything I might say in the next minute or so to introduce Dr. Cosgrove would be redundant. The clinic is so well known in our community, and his leadership is so legendary. Ever since the groundwork was laid for the Affordable Care Act, the outcomes-based approach that the clinic uses became national headlines, and Dr. Cosgrove has become perhaps the most famous healthcare executive in the nation, perhaps even the world. Maybe not. I don't know. But this evening, we'll talk about some items we don't all already know. We'll talk about where healthcare is headed in this world of innovation, big data, Obamacare, and what's happening behind the scenes that changes the healthcare that we all experience. We'll talk about this book and the healthcare industry trends that Dr. Cosgrove outlines. And we'll also talk about leadership and what it means to upend an industry as set in its ways as healthcare can often be. As CEO, Dr. Cosgrove is accountable for the performance of a $4.6 billion healthcare system comprised of the Cleveland Clinic, 9 community hospitals, 14 family health and ambulatory surgery centers, Cleveland Clinic, Florida, another one in Toronto, and a small project in Abu Dhabi. Cosgrove took over the helm of Cleveland Clinic in 2004, and the last decade has been perhaps the most successful in the healthcare system's history. Those last 10 years include not only a run of great rankings that you see every time you drive down Carnegie,
modesty is not our virtue,
but also the establishment of the Cleveland Clinic Medicine in Abu Dhabi, Toronto, Vienna, Singapore, and Seattle, and a successful $1.25 billion capital campaign. Dr. Cosgrove received his medical degree from the University of Virginia School of Medicine in Charlottesville. He completed his clinical training at Massachusetts General, Boston Children's, and Brook General Hospital in London. His undergraduate work, as it happens, was at Williams College in Williamstown, Massachusetts. Charming little town. He was a surgeon in the U.S. Air Force and served in Vietnam, was also awarded the Bronze Star. He started at the Cleveland Clinic in 1975, and with a few hundred scholarly articles, some 22,000 operations, 30 patents, and 1 book, it's been a pretty good career. Ladies and gentlemen, please join me in welcoming Dr. Toby Cosgrove. Good to see you. So, what took you so long to write the book?
slow writer.
Uh-huh.
Well, first of all, the book is sort of the culmination of a bunch of ideas, not just of my ideas, but the ideas of the organization. And the reason that we wrote it is there's so much bad news about healthcare going on right now, and everybody talks about crisis and how things are broken. And I thought that we had a model that had been very successful, had been held up as a model where we might be going in the world, and I think we did some things that could benefit other organizations. So I wanted to get it out there for people in healthcare and anybody else who's having trouble sleeping.
Thank you. It's been great. Slept really well the last week.
Good.
In all seriousness, you have an institution, you lead an institution that is unlike most healthcare institutions, and it probably rankles a lot of people that you're so darn good, and then the clinic has been so successful. What is it about the clinic that really sets it apart from every other hospital that people are familiar with, and that makes your competitors angry?
I think it's a story that starts right here in Cleveland, actually.
Mm-hmm.
We have a different model of care that was put together 95 years ago by our founders when they came together to work as a unit. And we are all employees. All of our excess is plowed back into the organization to continue to develop it. We're all salaried. We all have 1-year contracts, and we all have annual professional reviews. And I think that those things drive the quality and keep the eye on where the organization is going as a unit.
People outside of healthcare may not understand the significance of being paid a salary rather than a fee for a service. Can you unpack that for us?
Yeah, sure. Most people get paid for what they do. If you do an operation, you get paid so much for that. You do another operation, you get paid so much for that. It's essentially the fee-for-service model.
But literally, like if I work at a different hospital, I don't just get, I can't count on like a regular paycheck. I can only count on, you know, the number of knee replacements I do.
Interestingly, there's a saying in healthcare that you eat what you kill.
Really?
Yeah. That's that. So, not literally, guys.
Angela Townsend, did you catch that? Thank you. Okay.
So we are really quite differently. So at the beginning of the year, the salary is set, and that's what you get. And so it didn't make any difference to me if I did one heart operation or three that on a particular day. It made no difference at all in what I got paid. Now the interesting part and a really good part about that is I could honestly say to the patient, it doesn't make any difference to me financially, you know, whether I do your operation or not. I think you need it. And that's the reason we do it. So it takes the extra tests out, the extra procedures, and no one ever questions the fact that you're doing something just to generate return.
How did we get that system that is not your system, but the system that you kind of run counter to?
Well, I think, you know, this is a very, very unusual way that we all get paid in the United States, and I think it basically comes down to the fact that we're a country of entrepreneurs. And the professions were like that, and have been like that for, I mean, lawyers were similarly, and accountants were similar, and so you get paid on the basis of how much you do with something. Well, that's not how we do it, and I think that that's one of our main secrets of success. And by the way, the other thing is, you have to understand that we're a group practice, and we're
Small
not.
group.
And yeah, it's a group. It's, you know, it's interesting why you mentioned that. When I started out, we were 140 doctors here.
In 75.
In 1975. Now we're 3,200. So it's been tremendous growth of the organization over that period of time. In fact, we were one hospital, and as I look around now, it's hard to find what's left of what I came to. It's all been replaced or built up around. So it's been tremendous growth over that period of time. But so we're not physicians who work for a hospital. We're a group of physicians who govern themselves, elect our leadership, make our rules, enforce our quality, et cetera. So it's a very different model. Mayo Clinic is like that. Leahy Clinic is like that. Oxnard Clinic is like that, but not many hospitals that way.
That's one aspect. That's a whole chapter, and it kind of runs through the whole book. That notion of being this group practice and all of that.
That's our secret sauce.
That's the secret sauce. There's a lot of other innovations that are made possible because of that. So talk a little bit about some of those.
Well, I think one of the things that it allows us to do is, you know, when I have a problem, I call somebody, they're there. We're on the same team. We're all part of the group that is taking care of the patient. So if I need an endocrinologist or I need a pathologist or I need something else, they similarly aren't saying, well, how much am I going to pay to come help you? They just come. And so that we're all in this healthcare program together with the same objectives. So that allows us to do a lot of things. And plus, the other thing is, it allows us as a group to move rapidly. Mm-hmm. We can make decisions as a group, and then we can implement them. And that's a tremendous advantage.
You know, reading this book, I was struck by the fact that...
Did you really?
I did.
Okay.
I did. Although sometimes I just like to say that because it makes me sound erudite. But I was really struck by the fact that when you have that model, that collaborative model, you basically overcome all of the problems that the medical industry has evolved and created for itself, everybody's specialization. The fact, for instance, that a urologist and a nephrologist might not actually be working side by side, but ought to be.
Well, that's another thing that we did. About 8 or 9 years ago, I had worked on the experience that I'd had coming to the Cleveland Clinic, and when I came to the Cleveland Clinic, there was a waiting room, and on one side was the cardiac surgeons, on the other side was the cardiologist. Yet I was in the Department of Surgery, and they were in the Department of Medicine. And, you know, I had nothing in common with my fellow surgeons. I mean, there were colorectal surgeons and gynecologists and neurosurgeons, and we didn't see the same diseases, we didn't work on the same patients, but I had everything in common with the cardiologist. I mean, we looked after the same patients, we looked after the same disease processes. I would go to the cath lab, they would come to the operating room, we went back and forth. And so it really occurred to me that healthcare had been organized really around the guild system. That the surgeons were in one guild, and the medical people were in another guild, and the pediatricians were in another guild. And the hospital was organized around doctors. And I thought, well, wouldn't it be neat to organize a hospital around patients?
Whoa.
Well, a shocking idea. So what we did is we organized ourselves by our organ systems, like the neurologists and the neurosurgeons and psychiatrists are all in the Neurologic Institute. The cardiac surgeons, the cardiologists, the vascular surgeons, vascular medicine, all on the Heart and Vascular Institute. And the interesting things that came out of that was you put all these people in the same location and they bump up against each other at the water fountain or at the coffee pot. And they'll say to each other, and I've done this myself, Mrs. Jones is in there, I just don't know what to do. What do you think? And out of that will come new thinking and innovation. And that's where innovation happens. It happens at the borders of knowledge.
Does that really happen, or is that just a nice story?
No,
like,
absolutely.
oh no, I was hanging out by the coffee machine.
No, absolutely. So let me tell you what happened in orthopedics. The orthopods were seeing all these people with fractured hips, and we put them in with a rheumatologist. And all of a sudden, the rheumatologist said, well, did you ever look at the calcium metabolism of these people? And these guys go, orthopods don't read.
Noted.
But anyhow, so they said, gee, we ought to start. So they started a whole study looking at the calcium metabolism of these patients. So it really does happen. And we're replacing heart valves now on catheters. Mm-hmm. And so you go into the cath lab with an anesthesiologist, puts the patient to sleep, a cardiologist, a cardiac surgeons, an echocardiographer, and they run a catheter up through the groin into the aortic valve. They explode the valve in place and sew up a little incision about like that in the leg. That's it. But it requires all of those specialists working together in a room that we specifically built so they can do this together.
This is a surgery that you just described 20 years ago would have required you to split ribs and stuff like that.
Well, no, down the middle. It's not ribs.
Yeah. Okay. I don't know these things. That wasn't in the book.
Yeah, he did know that ribs are the favorite meal of a thoracic surgeon.
Yeah, are they? Yeah, there's something. Yeah,
Just saying.
Yeah. Okay. Also noted. Let's spend the next 30 minutes talking about the electronic medical record.
Yeah.
Just
Good.
kidding.
I ought to clear the room out.
No, in all seriousness, the EMR has done, this is one of these things that was made possible because you have all these people together in one place, and you're only paying them you're paying them a salary and not fee for service, and there are suddenly all of these possible benefits of everybody sharing data. So, what have we gotten so far?
So let's go back and think about what's happening in medicine. Medicine is moving from an art to a science. And with science, you have to put numbers to it. And you got to keep track of the numbers somehow. And it has gotten to the point so there's vast amount of numbers. And so the logical thing was to be able to have some way to keep track of these. And the electronic medical record is the way to keep your record and move it around and keep the numbers, et cetera, that go with it. Now, as we got into this, we began to realize that this was big data. And it's gotten to be big data when you stop and think about the human genome, which is essentially billions of bytes of information, bits of information. What has come out of this is a very interesting thing here in Cleveland. A spin-off out of the Cleveland Clinic is a company called Exploris. Mm-hmm. Exploris has now got 45 million patient records from all over the country. Now think about the amount of data that there is in that. I mean, think about the data for research. Let's say that and they showed me this one day, they said, well, how many, I said, we want to do research on a patient with diabetes, and we want to know how many people are 45 years old or older who are taking this drug in your registry, and they go clink, and 2 nanoseconds later, you've got the entire list for you, and you can begin to look at all the other things that are associated with that. This is the age of big data and beginning to mine it and predicting the complications that are going to go with it, the side effects of drugs, and the biggest data center is right here.
The biggest data center, what, on the planet?
Yeah.
In Cleveland? What?
Yeah.
Really?
Yeah, 45 million.
That's, how far back, the data, because I know when the clinic first started digitizing medical records.
It was 8 years ago.
8 years ago, and you went back to?
No, we went forward.
You only went forward?
Yeah, we did. We have, for example, we've been keeping registries for a long time, and one of the great things that my predecessor, Dr. Loop, did is he really introduced us to the understanding of data. And back in 1972, the clinic started registering everybody who'd had a cardiac surgical operation or a cardiac catheterization. And then they would follow them up every 5 years. Mm-hmm. And so we had, from that, we learned about what the right operations were. And over time, this changed the practice of cardiac surgery, not just at the Cleveland Clinic, but across the world from the data that we collected there. So we have well over 100,000 patients who had heart surgery who have been followed out 10, 15, 20 years until they die. Millions of dollars, by the way, was invested in that, and it's been well worth it.
Is it saving, because now it's saving lives and saving you probably millions of dollars as well?
Well, I mean, it's saving lives, but I mean, think what that means for society. I think that's an interesting point. Everybody talks about the cost of healthcare, mm-hmm. and it's gigantic, no question about it. But on the other hand, think about the expansion of life. In my lifetime, the life expectancy has gone up about 10 years. And those people pay taxes, they buy things, they have homes, they drive cars, they contribute to society, and they are a major influence on the economy of the United States. There's some, Mark McClellan, who is a doctor economist, wrote with a bunch of economists in a book coming out of Chicago, University of Chicago a few years ago, that 50% of the growth of the GDP in the United States has, over the last 20 years has been from the increasing life expectancy. So, it's while it costs something, we never talk about the other side of it and what it means in terms of society. And that doesn't count the companies that manufacture things, the exports that go out of this country. It's a huge industry that really has a positive effect, not just on length of life, but also on the economy.
I just want to repeat that so I get it. 50% of GDP growth is a result of the increase in life expectancy.
Yes.
Wow. Okay. That's kind of mind-blowing. With the big data stuff that you guys are doing now, how much are you able to predict about outcomes and avoid pitfalls?
That's a really interesting thing, because I was able to, a number of years ago, recruit a guy by the name of Gene Blackstone. And Gene is a gentleman who established all the ways that you look at life expectancy and complications around cardiac surgery, and developed all the ways. And so now we predict the operative risks from people preoperatively, looking at all their factors that go into it. We can predict the risk factors, and we can predict the life expectancy afterwards. And we also see that by doing multivariate analysis, you can begin to look at what causes the risk around surgery. Now, the most amazing thing, it used to be size and women and renal function and age. Those have all disappeared. You know what the biggest risk is right now? Whether or not you get a heart, or you get a blood transfusion. So all of these things, over time we've begun to understand all these little things and begin to alter our procedures so that you take those risks out.
Is that because of the safety of the blood supply, or is that just because it's an indicator of something of a bigger problem?
It's probably a result of the fact that a blood transfusion winds up changing the immune system. It's not that you're getting hepatitis from it. But it clearly does affect the people's immune system and their potential for infection and respiratory problems, et cetera.
I want to switch gears a little bit to leadership. I know I've jumped around a lot already, so if you can keep up.
I'll try.
Okay. When I first moved here in 2005, the rap on the Cleveland Clinic was that the clinic was not a great collaborator and was kind of a big dog in town and didn't have to collaborate with anybody. About 20 minutes ago, I was talking with Akram Boutros outside, and he said of you and the Cleveland Clinic, and Akram, of course, is your counterpart at Metro Health Medical Systems, or Metro Health Systems. Did I say it right? One of those. Metro Health. And he said we collaborate more than we compete.
Yes.
And now the Cleveland Clinic and Case Western Reserve are embarking on a new medical school.
Right.
How hard has it been for you to change the culture in your giant organization to become more of a collaborator externally?
I don't think it's been hard for the organization. I think that the thing that has made it are two of these people are sitting here in the front row. Dr. Boutros and President Snyder. Both have been individuals who are very open to collaboration, and frankly, I think we're going to be much stronger as an organization by collaboration than we ever would have been independently.
What's been the hardest thing, though, about changing culture in your organization? Because organizational change is one thing, but as they say, culture eats strategy for breakfast.
It does.
Yes.
I think clearly nobody likes change. Nobody understands change. Everybody's comfortable with the status quo. And I think I thought I could make an impact on the culture of the organization in about 2 years. And essentially it was about 5.
Uh-huh.
And one of the things that I think that I've learned is in physicians particularly, and physicians being leaders, you have to give them the data. If you give them the data and you explain the situation, and you may have to give them the data more than once, by the way, like over and over and over again. But if you give them the data and they understand the data, then they're willing to change. But they're not going to change unless you can give them the data and make the case why it's important, and then you can move the organization. By the way, the other thing that we've done, we're big on transparency. Mm-hmm. And transparency is not just transparency of what goes on in the institution to the outside. It's also what goes on in the institution to the rest of the institution. So I learned an interesting lesson early on, and we were having a tremendous amount of blood use in heart surgery, reoperation surgery. And so we used to have at each department meeting, we'd put every surgeon's name up there and how much blood they were using.
That's
the blood
shaming.
In order. And the blood utilization dropped like a rock. And we've continued to do that. And so now...
you just shame everybody?
No, hey, they all went to medical school and no one wanted to be last in his class.
Oh, okay.
And the grades were right out there. So, we are transparent, and so for the patient satisfaction scores, the complications, we post them by name and rank order. And we've just gone to something new, which is now about a year into its utilization. We do forced ranking of docs by institute. And so the top 10, the middle 80, and the bottom 10%. And we think that the top 10 ought to be celebrated. Top 10% ought to be celebrated. The bottom 10 ought to be coached and moved up. And it is amazing the transparency and what it does to driving quality.
Mm-hmm. Does that mean that ultimately everybody moves up? Because you're always going to have a bottom 10%. That's kind of the bummer of that.
Well, that's true.
Uh-huh.
But you don't want to be there. Well, it crossed the organization. It's lifted the entire organization. It really has.
What would those folks who had been at one point in the bottom 10% say about it?
They'd probably say they're damn glad to be out of there.
Uh-huh.
Not out of the institution, out of the bottom 10.
Medical school has changed a lot, and I know you're hoping to change it even more. Where are you pushing it?
Well, we have a wonderful relationship now with Case Western Reserve University, and as you know, they're the degree granting institution for the Lerner College of Medicine and for their medical school. And when I had an opportunity to sit down with Dr. Snyder, we talked about whether we could bring the two schools together in the same location. And so what we're doing now is, putting together a new physical plant, which she needed, and it will be on our campus. But there's two things about it that we really want to do. We think that healthcare has gone from an individual sport to a team sport. And the reason that is the explosion of knowledge has gotten so big. And the total amount of knowledge in healthcare doubles every 2 years. So nobody can keep track of all this. And so what we've done is we've sliced it all up so everybody's got to depend upon a lot of specialists to help. And so it's a team sport now, and we want to teach team sport right from the get-go. The second thing is that the pedagogy has the potential to change now, and many of you have heard of MOOCs, which is computer learning. We've watched this in a very interesting way, and one of the big approaches now is being done at Georgia Tech. And there's a company called Udacity that combined with Georgia Tech, and they're now offering a completely online master's degree in computer engineering for $6,000. And that's opposed to $44,000 if you're taking it on the campus. Now, fast forward, think about the pressure that's coming now around the number of physicians that we're requiring. We're expected to be over 65,000 physicians, primary care physicians shortage by 2025. And then you think about the demand for physicians all over the world. Wouldn't it be great if Case developed the course for, let's say, biochemistry that was used all over the world? Mm-hmm. I mean, that scales. It reduces cost, and it meets the demand. And you learn at your own speed. You can go back and learn it over again. Most people will probably learn it in 6 months. I would have been there still a year and a half later. But you manage to think about this in an entirely different way. The other thing that we're talking to IBM about is bringing in Watson. And for those of you who are unfamiliar with Watson, Watson was a supercomputer that took on all the Jeopardy champions and cleaned their clocks.
He's also good at chess, I think, right?
Yeah.
Yeah.
So Watson is going to medical school now at the Cleveland Clinic. Watson can read the entire medical literature in the time that this talk will take, mm-hmm. And remember it all. So now with this explosion of knowledge that we have, and the ability to go and take that sort of knowledge and incorporate it and analyze it, you have a tremendously powerful tool. Right now it's being used in cancer, because you're doing the human... The tool what? Watson is being used? Watson is being used and trying to decide how you manage patients with cancer, because you're now doing the genome sequencing, mm-hmm. on a tumor. You then have got the choice of, so maybe half a dozen drugs.
And you can say, Watson, of these half a dozen drugs, which of these would be most appropriate for this cancer in this patient?
And you also want to know how old is the patient, what their renal function is, what their kidney function is, what their gender is, how big they are. What Watson can give you the algorithm about the potential for the best drug to use and the amount of drug.
Does Watson also have access to your 45 million electronic medical records?
Not yet.
Soon?
Well, coming to a neighborhood near you.
So, I mean, part of what you're pointing to is that medical professionals will have to be much more comfortable with computer science.
Absolutely.
Is that part of the coursework? Barbara, are you there? Yeah?
We're getting there.
Okay. But that's part of the deal.
That's one of the things we want to make people comfortable with.
What about the non-Android part of of medical care, the empathy. I think there's a
That.
chapter in here
Yeah.
about that thing. That was, and you said that that was kind of a big aha moment for you when somebody asked you, like, do you teach empathy at your medical school? How's that going?
Okay, so let me, I guess should I tell,
You want to tell the story? Tell the story.
The story is embarrassing, but I think it makes a point. I was at the Harvard Business School, and they're doing a case study on the Cleveland Clinic. And, for the first time, I was down in this sort of horseshoe answering questions, and a girl in the second row raised her hand and said, Dr. Cosgrove, my father, who's a doctor, had mitral valve prolapse, and we know that you've done more of those than anybody else in the country. But we decided not to come to the Cleveland Clinic and you, Dr. Cosgrove, because we heard you don't have empathy. Phew, is right. And so I was absolutely stunned by that. And so then I stopped and looked at my career and what I was doing. And I'd started out as a medical student at Boston Children's Hospital. And one day in heart surgery, we lost 5 kids. And when I was a resident at Massachusetts General Hospital, the mortality rate was double digits. And there's a saying in cardiac surgery that cut well, sew well, do well. And so I spent all my time in the operating room refining my craft, doing better and better, worrying about the complications, developing instruments, all that sort of stuff. And the more I did, the better I got. And I was spending all my time in the operating room. And I was not spending my time with the patients. And I realized that I'd become a technician. The mortality rate was now 1% or less. But, the patients now, instead of giving you a hug because they survived, wanted to have a relationship with you. And so I said, we've got to put the empathy and the humanness back into healthcare. So we developed a new C-level job called Chief Experience Officer. And we then, as we thought about it, we said there's really 3 things that count quality in healthcare. It's the clinical outcomes. In the clinical outcomes, we've been writing outcomes books and being very transparent about that for a number of years. There's the physical experience and the emotional experience. So we started with the physical experience, and we got Diane Van Furstenberg to help us design a gown that completely covers you as a wrap. We worked on the architecture, we cleaned the place up, we straightened and neatened it up, we worked on all the physical stuff. And then we started to work on the emotional stuff, and it really took us to begin to redefine what it is to work in a hospital. And so one day I had this experience of seeing that a patient's entire hospital experience was ruined by a situation where they found dust bunnies under bed and an empty IV bag. And in cardiac surgery, 130 individuals touched that patient during the course of their hospitalization. So just the fact that somebody either threw the bag under there or didn't clean up ruined the efforts of the cardiologists, the cardiac surgeons, the anesthesiologists, the intensive care nurses, the technicians in the operating room, the nurses on the floor. All these 130 people were ruined by this one thing. So I said, we've got to change the organization because it's a team sport and anybody can screw it up. So what we did was we took everybody offline for half a day, and we sat them around the tables like this. And we talked about the Cleveland Clinic experience, and when everybody came out of that, they all got a badge that said caregiver. And we talk about everybody in the hospital as being a caregiver. Whether they work in the loading dock, or they deliver the food, or they clean the room, or they're a neurosurgeon. And that began to change the organization when everybody realized that they're part of the team. And we've gone, if the hardest place to get patients to feel good about their experiences in big hospitals. It's easy when you got 25 patients in a small hospital, but it's harder when you got 1,400 beds. So when we started this 5 years ago, of the 17 hospitals in the country with 1,400 beds, we were last in patient satisfaction. We've gone from last to first in 5 years because we've concentrated on it, and it really has made a difference in the patient's experience.
Congratulations. That's a big deal.
That's congratulations to the organization.
Yeah. We are going to transition to the Q&A in a moment. There's a little bit of housekeeping to tend to. If you're just joining us on the air, you're with the City Club, and we're enjoying a special program with Cleveland Clinic CEO, Dr. Toby Cosgrove, He's the author as well of the Cleveland Clinic Way, Lessons in Excellence from one of the world's leading healthcare organizations. We welcome all of you here and those joining us via 90.3 WCPN, WVIZ PBS, 104.9 WCLV Idea Stream, or one of the many radio stations across the region and country that carry City Club programs. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. Tomorrow, July 25th, the City Club welcomes Amy Hanauer, Executive Director of Policy Matters Ohio. For more information about any of our upcoming or past forums, please visit us online at cityclub.org. Today's program is made possible by our community partners, the Cleveland Clinic and the Center for Health Affairs. We thank you both for your support. We also welcome guests at tables hosted by Richard L. Bowen and Associates, Case Western Reserve University, the Center for Health Affairs, Cleveland Clinic, Cuyahoga Community College, Genomic Medicine Institute at Cleveland Clinic, the Global Center for Health Innovation, Karpinski Engineering, Medical Mutual, Time Warner Cable Media, and Winfield. We thank you all for your support. Now it's time for the traditional City Club Q&A. We welcome questions from all of you, including guests. Holding the microphones today are Associate Director of Advancement, Mike Cromaldi, and our new Director of Programming, who we stole from the clinic, to be perfectly honest, Stephanie Jansky. Our first question, please.
Dr. Cosgrove, there's been a lot of publicity in recent years regarding the clinic and your attitude toward reform. How much impact do you see that's had on the healthcare system in general throughout the country? Do you see more hospitals looking to the clinic and Mayo Clinic and places like yours to, as a model?
Well, I can't tell you whether they're looking at us or not, but what I do see is I think there's two things that are happening that are closer to what we are. First of all, now about 65% of physicians in the United States are salaried, and the vast majority of those are employed by hospitals. Similarly, hospitals are coming together in systems, and about 2/3 of the hospitals are part of a system. So I think that you're seeing a movement that is probably similar to looking more and more like the Cleveland Clinic health system. Whether they're looking at us as a model or not, I can't tell you.
We are very fortunate to have a leader like you. And since you are more compassionate, can I ask you this troubling question, which always have been in my little head tied up? Why the industry calls this in healthcare when it is in truly a sickness care?
I'm glad you asked that. That's a great question. I had no idea that I was going to be a CEO. And so I had about 6 months from the time that I found out that this was going to happen until the time I actually had to take over. And during that time, I asked myself these questions. I said, what industry I'm in? And I said, I'm in healthcare. And then all of a sudden I went, geez, I've been in healthcare for 40 years and I've never looked after anybody who was healthy. And so I said, we really need to think about how we move from sickness care, as you point out, to wellness. And so we started out down that road, and we thought that the way that you begin to do this is, you've got to set the model and you've got to clean up your house first. So the first thing we did is we said, I said a lot of things, but some of them were okay. The first thing that I said was, okay, we've got to stop smoking. And so we'll give free smoking cessation to everybody, and you can't smoke on our campus. And then we reached out into the community, and you may remember there was a big referendum about smoking in public, and we campaigned hard for that, and it got passed. And then we reached out into the community, and we gave free smoking cessation to anybody who didn't have insurance. And then finally, after we got a new head of HR, we stopped hiring smokers. And this was a move that was roundly criticized. But I thought we needed to set the example of, about smoking. Subsequently, other institutions around the country have done this, healthcare institutions, and then we moved from there to food, and we changed the food. We took the sugar drinks out of the vending machines. The Snickers bars are gone. The fryers are out of the cafeterias. And then we went to exercise, and we offered free Weight Watchers, free curves, free access to our gyms, to all of our employees. And over that time, we've lost 450,000 pounds. What? And the smoking incidence in Cuyahoga County has gone from 27% to 15%. So you can make a difference in the community. And I'm happy to say that the Board of Regents in Ohio recently recommended that all the state schools ban smoking on the campuses. And now I think that there's 13 of them that have gone ahead and done this.
Including Cleveland State?
Including Cleveland State and Ohio State.
Mm-hmm. Next question.
Hi, I'm a physician in a independently owned 6-physician pediatric practice. We're one of the very few independently owned practices left. And my question is, what do you think the future holds for independent practices? Can we coexist with the larger institutions in Cleveland, or do we have to totally change our model of care?
No, we want to make our collaboration with people in private practices as easy as possible. In fact, one of the things that we did is we put together the Quality Alliance, which has now got over 5,000 caregivers as part of that. And that brings in quality metrics and that drives quality across the organization, and is a collaborative effort between us and the private physicians. Now the trends are across the country that about 85% of students graduating from medical school want to be salaried. And the other issue is that this explosion in knowledge that we talked about, now I think it makes it difficult for smaller groups to manage to surround all the specialties that you need in the knowledge. And as the knowledge explodes and explodes and explodes, you're going to need more and more people to cover that. The third thing is that the expense of running a practice with the requirement for computers and the complications of contracting, et cetera. All these things I think make it increasingly difficult for small independent practices to thrive. I absolutely do not want to drive physicians out of private practice. That's not our desire at all. But the pressures on people who are in private practice, I think, are mounting, and the trends, I think, are fairly obvious. Fair?
Good evening. I'm sorry I'm late in telling you this. You might have wanted to put it in your book, but my grandfather, Dr. Manning, used to practice over at St. John's Hospital with another doctor named Dr. Kreil. And Dr. Kreil asked my grandfather if he wanted to come over to the east side and start a new clinic. And my grandfather said, no, my patients are here, we're staying here. So. But my question for you is, if you could look into your crystal ball, where do you see this Obamacare ending up?
Yeah, that's a sort of $64,000 question. I think we knew that we had to have a change in healthcare. And the reason is that healthcare is now consuming 18% of the GDP. If you look at every state's budget, it's the biggest part of every state's budget. It was starting to crowd out things like education and other social programs that we all want to see. And the demographics were moving along so that there was a bigger and bigger population of people greater than 65. 10,000 people every day turn 65 now. And so that population is growing, and the technology is getting more and more and more sophisticated. So people were worried about the exploding cost of healthcare. And by the way, that's true in every country in the world. They're all seeing the same thing. So we knew we had to change. The question is how to change. I think that we have a massive law. My concern about the law is that it's going to have unintended consequences. We don't know what they are. And the real thing I'm worried about is, are we going to be able to be flexible enough and move with enough alacrity that we can minimize the unintended consequences of the law? And I think that's a question for Washington that will remain unanswered. It's a 3,000-page document with 10 times that amount of regulations that go with it.
And litigation.
I heard.
Dr. Cosgrove, my wife and I are huge fans of yours and your institution, particularly the last 4 months because of our personal situation. And we are also huge fans of the usage of data and trying to refine, and I love the way you said it, from an art to a science. What complications do you have with HIPAA or people saying, hey, this is my data, I want my privacy, and you know, we all know that's important, but to have all that in the database is key. So how do you manage it?
Okay, well, first of all, as you probably know, there's some laws that prohibit using that data in making insurance. So and similarly, there's the HIPAA violations. And so we can tell when someone has gone into a chart. We know every time someone's gone in. Periodically, we'll find someone who goes into a chart has no business being in it. And you know, we've fired people on the spot because of that. And so we're pushing really hard. Now, this is a very big issue. It's an issue that gets even bigger when you think that someone could put a thumb drive into a computer and take a whole bunch of data and walk away with it. And then there is forwarding of data. And there's all kinds of ways you can get into it. But on the other hand, let's look at what we had before. We had a chart that sat on the desk in a clinic, or stacks of charts that were this high, or rooms full of charts this big that had virtually no protection. You could go in, you could pick it up and look at it, and no one would ever know that you looked at it. So while there is concern about this, I think there's also a step ahead, and we're going to get better and better and better in encrypting this information as we go forward. I think the advantages of the electronic medical record far outweigh the risks.
Just to clarify, when you're doing this big data stuff, you're anonymizing the data.
Oh yeah.
Right.
Oh, exactly.
Okay.
Yeah.
Dr. Cosgrove, 32 years ago, a snotty-nosed kid put an aortic valve in my heart, replacing an infected valve. And Christmas Eve, a few days after the surgery, they were putting a pacemaker in. And who walked into the room but this snotty-nosed kid and said to me, "Terry, how you doing?" And what's more important is 32 years later, when that valve was replaced, the first person I saw was this snotty-nosed kid who's now CEO of the Cleveland Clinic. And he said to me, "How you doing, Terry?" And I thank you. It speaks well for your empathy.
Well, thank you very much. I'm going to have to get a handkerchief. Thank you.
Dr. Cosgrove, there's a lot of pressure with the Affordable Care Act on institutions like yours, especially on the revenue line. Can you share what the Cleveland Clinic maybe is doing better than most to offset that pressure on revenue in terms of really managing your costs and continuing to deliver quality care?
Okay, well, let me put it in perspective for you. First of all, we know that what we get paid is going down continuously. And over the next 10 years, there'll be about $415 billion taken out of Medicare payments. We also know that every insurance company is not giving us inflation like they used to be. They are now giving us flat or decreased payments. Further, we all know that you all are now being held responsible for more and more of your health care bill. And now 44% of insurance is high deductible, meaning that you're going to pay the first $3,000 to $6,000 of your bill each year. And so we are not, you know, our revenues are going to go down, and they're going to go down for every institution across the country. Now, our CFO projects that we're a $6.5 billion organization. And we think that over, barring growth or expansion, you know, if we stay just the same, we've got to take about $1.5 billion out of cost to stay financially where we are. That's about $300 million a year. And you know, we're on that journey now, and we're looking at all kinds of things. And just like things at home, when you begin to look, you find that there are ways that you can trim fat. We've done a lot of that already. We took about $100 million out of purchasing last year, and that is by going to the physicians and saying, look, you know, if we use this particular thing instead of having 6 hips on, and you know, we'll negotiate for 2 hips and with a company, and we will get the same quality hip, but we'll get it at lower price. And we've done a whole bunch of those sort of things. We've looked at turning off escalators. We've looked at changing the size of the bottles of soap for prep solutions and saved $300,000 in that process. So there's just all kinds of things that we have to do. But you know, a lot of these things are going to be done around developing what's called care paths. And all of you know, in manufacturing, if you have variation, it makes the quality less, and the costs go up. But if you have a constant way of doing something, it gives you constant quality and decreases cost. We've seen that already. We've got about 30 care paths that we've established. We've seen, for example, in hip replacement, the patients stay less time in the hospital, the blood utilization has gone down, the cost has gone down simply because everybody is following a proven approach to this. So, you know, I think it's good that the pressure is on us. There's no question that we're feeling the pressure. And so is every other institution around the United States.
Cosgrove, my family and I have been huge consumers of the clinic and have really enjoyed the clinical services. And we have also observed many, many improvements over the years while you have been in your position. I have 2 real big concerns. They might be small, but for me they're really big. One is your billing system. It's very, very hard to handle. And I think myself, I have the time, and I have the computer, and I have knowledge to deal with it. But people who don't have that, I don't know how to do it. And I don't understand why it's so hard to make that easier. The other thing that I'm concerned about is your telephone system. It's impossible to call somebody. Like, I had a doctor calling me from Beechwood, asking me to call her. I called the number, and I got the main campus, and then I got Beechwood, and then I got the surgery instead of the family practice, and then I was disconnected. And it happens again and again.
Okay.
So that's one question. I have one more I would like you to...
3 concerns? Or I'm just playing. Go ahead.
No, I would like you to address the issue around the, I don't remember what they're called, express care clinics that you have started at the family practice. I understand they're primarily staffed by nurse practitioners and physician's assistants, and I think it's a wonderful idea because it must reduce the cost. And I just want to know, what are your plans for that, and how is it received in the medical community?
I'm not sure I understand the last part of your question, but yes, we do have express clinics, and they are manned by physicians' assistants and nurses. But let me just address the telephone issue and address the other. The telephone issue, about years ago, we recognized that there were 60 phone numbers that you could call to make an appointment for a neurologist. And we thought that that was ridiculous. So we put together a call center. The call center now takes about 3 million calls a year. At the call center, there's almost 500 people who work in patient access and manning the call center. We do not have that perfect by any stretch of the imagination. We have, and frankly, there was no roadmap to follow when we put it together. So we had to put it together from scratch, and we've made mistakes, and it's not worked efficiently, and we're back at it, revamping it again now. The second thing about, I have to tell you a little story. So when I first became CEO, I get a call from Senator Voinovich. And he said he'd like to come see me. And so I said, of course, Senator, come right up. So he came in and see me, and he reached in his pocket, and he took out his bill. And he said, I don't understand this. Could you explain it to me? And I said, you know, Senator, I've never sent a bill, but I'm going to call the guy who's in charge of this, and he can explain it to you. But unfortunately, I have to go to the operating room right now. So up comes the guy from finance to explain it to you. And this really gets bad. I come back down, and I said, well, you know, how did it go? It turns out he couldn't explain it either. So yes, we do have an issue. One of the things we did do is we went to a single bill. And you know, generally, if you go to a hospital, you might get a bill for the anesthesiologist, the surgeon, the radiologist, the hospital, et cetera, a whole series of bills. So we asked them, you know, and it took us about a year and a half to get it on one bill. And that's where we are now. But we are a long ways from being the most efficient billing system. And I would take that criticism, and I've heard it more than once.
Hi, Dr. Cosgrove. Big fan of the clinic, big fan of you. Have seen over the last 5 years all the improvements personally with my family. I don't want to end on a bad note, but I'm just curious to get your input on all this big data. Is it going to be viewed in a negative fashion that we'll take a look at where if we have trending in certain areas that are, you know, increased mortality, are the hospitalization companies going to deny care?
Huh.
I think can I take that just to a little higher level for a second? You know, the quality measuring quality in healthcare is really difficult. I've been at it about 30 years, and we started out in cardiac surgery, and cardiac surgery is probably the easiest thing to measure quality in because you have sort of two endpoints: you either walk out or get carried out. And then, in order to understand it, we had to become increasingly sophisticated over time and begin to risk assess. Because if you're 95 and you come in for an extensive third-time operation, your risks are substantially higher than if you're 45 and this first time around. So that was a whole exercise in trying to do this. And then we found it was related to the patient's size, and then we found out it was related to their renal function, and then, you know, and so it went on and got more and more and more sophisticated, trying to understand which high risk was. Now you take that same thing and you multiply it by all the specialties, whether it's orthopedics or dermatology or whatever it is, and so you can imagine that you can't just take risk and drive it down really specifically very well. And so what's happened now is that the government and all the rating agencies have taken very sort of simplistic across the hospital sort of risk factors. You know, did you get readmitted? Did you have an infection? Did you fall and break your hip? Was there surgery done on the wrong side? All those sorts of things, which are really not getting very granular about quality. So just let me take where I'm going with this. So you know, everybody says, well, we really need to think about value, and that's the function of cost and quality. Now, my contention is that what's going to happen is we're not going to be able to measure the quality in a significant enough way, and so it's going to be reverted to cost. And we will see more and more decisions made on the cost, and that will get driven and driven and driven down as transparency around cost comes about, people will then shop more and more because they have a responsibility for it, and because quality is going to be so hard to measure that it's going to be overwhelmed by the cost factor. So, you know, I don't know whether the insurance companies are going to actually do cost or quality, or they're going to do cost. I'd bet on cost.
Dr. Cosgrove, you certainly earned your rib dinner tonight. Dr. Cosgrove is the author of the Cleveland Clinic Way. It's got a long subtitle I'm not going to bother with right now, but it is for sale out in the lobby, and they're signed, which is really nice. Thank you so much for joining us, Dr. Cosgrove. Ladies and gentlemen, thank you so much for joining us as well, for your wonderful questions and your attention. Our forum is now adjourned. That was great. Watch out.